السلام عليكم ورحمة الله وبركاته. ألتقيكم مجددا أعزائي طلبة المرحلة الخامسة في طب الأسنان ومحاضرة جديدة من محاضرات مادة طب الفم تلقيها على مسامعكم تدريسية مدرس دكتورة وداد فرحان جابر، تدريسية في كلية طب الأسنان جامعة الانبار. عنوان محاضرتنا إن شاء الله Autoimmune diseases. بداية خلينا نعرف شنو الأوتوإميون ديزيز. Autoimmune diseases disorders in which there is evidence of an immune response against cell. Autoimmune disease may be primarily due to either antibodies, autoantibodies, or immune cells, but a common characteristic is the presence of a lymphocytic infiltration in the target organ. Examples include type 1 diabetes mellitus, autoimmune thyroiditis, Sjogren's syndrome, SLE, and multiple sclerosis. Autoantibodies. In some autoimmune diseases, B cells mistakenly make antibodies against tissues of the body. This is called self-antigens instead of foreign antigens. These autoantibodies either interfere with the normal function of the tissues or initiate destruction of the tissues. Now we talk about typical features of autoimmune disease. Significantly more common in women, onset often in middle age, family history frequently positive, levels of immunoglobulin autoantibodies usually raised, circulating autoantibodies frequently also detectable in unaffected family members. Often an increased risk of developing other autoimmune disease. Immunoglobulin and or complement often detectable at sites of tissue damage, for example, Bempicus vulgaris. Immune suppressive treatment frequently limits tissue damage. كل هاي كانت features خاصة أو يمتاز بها البيشنت اللي عنده، ممكن يصير عند البيشنت اللي عنده autoimmune diseases. So autoimmune disorders fall into two general types. We have two general types of autoimmune disorders. The first one, those that damage many organs, called systemic autoimmune diseases. The other type, those where only a single organ or tissue is directly damaged by the autoimmune process, and this type called localized. So we have systemic type and localized type of autoimmune disease. The first one of this disease we take as example, and it is considered as archetypical or a good example of autoimmune disease, is systemic lupus erythematosus. Systemic lupus erythematosus is a multi-system autoimmune inflammatory disorders of unknown etiology. It is regarded as the archetypical autoimmune disease, as we say. Common symptoms of lupus include painful or swollen joints and muscle pain, unexplained fever, red rashes, most commonly on the face, chest pain upon deep breathing, unusual loss of hair, pale or pulpal fingers or toe from cold or stress, that's to say, or we call it rhinoids phenomenon. Sorry. Sensitivity to the sun, swelling, edema in legs or around eyes, mouth ulcers, swelling glands, extreme fatigue, and kidney problems. lupus erythematosus could be either systemic lupus erythematosus or isolated cutaneous lupus, we called it chronic discoid lupus, or could be drug-induced lupus is recognized. So we have three types of lupus erythematosus: systemic, isolated cutaneous, and the third type is drug-induced. That's to say, يعني lesion caused due to use of a drug. Unlike SLE, drug-induced lupus rarely affect the kidney and is reversible on the discontinuation of the offending agents and medication. هاي حتى نفرق بين drug-induced lupus and the two types الأخرى السيستميك والisolated cutaneous. حالة الدرج-induced الكدني ما تتأثر ويصير resolution بالحالة عندما يترك المريض الميديكيشن أو الدرج اللي يسبب له هاي المشكلة. فهذا يفيدنا حتى نفرق بين هذا النوع بين ال other two types الأخرى. Etiology and pathogenesis. Although the exact etiology of SLE is unknown, a complex interplay genetic and environmental factors that leads to a progressive loss of peripheral tolerance and the production of autoantibodies is believed to be crucial for SLE initiation. Other causes include exposure to pollutants, hormonal factors, ultraviolet light, and smoking. Diet has been linked to the development of SLE. In addition, over 80 drugs, hydralazine, isoniazid, procainamide, and other drugs could be associated with drug-induced lupus. So we go to clinical manifestations of SLE. Skin is affected in up to 85% of SLE patients. In addition, cutaneous lupus can occur without multi-system involvement. ممكن just بالسكن نشوفها بدون يعني باقي أجهزة الجسم تصير عندنا مشكلة. Skin lesions of lupus can be classified into lupus specific and lupus non-specific. Lupus specific lesion having diagnostic, clinical or histopathological features. والother type قلنا non-specific lesion. So the skin lesion we have two types, lupus specific and lupus non-specific lesion. Three types of lupus specific skin lesions. The first type اللي هو قلنا lupus specific lesion راح نرجع نقسمه إلى ثلاث أقسام اللي هي الأكيوت، السب أكيوت and chronic. الأكيوت type راح يكون موجود occur in 30 to 50 of patients and is classically represented by the butterfly rash. هذا characteristic features هو butterfly rash. Bullous lupus and localized erythematous papule also belong to this category. هذا بالنسبة للأكيوت cutaneous. نيجي على النوع الثاني اللي هو chronic cutaneous lupus occur in 15 to 20 of cases and affects the skin of the face or scalp in about 80% of cases. Subacute cutaneous lupus, the third type, refers to or consider the least common type, occur in 10 to 15% of patients and includes papulosquamous, psoriasiform, and annular polycyclic eruption, usually on the trunk and arms. These three types related to lupus specific lesion اللي حكيناها هسه اللي هي الأكيوت والسب أكيوت والكرونيك. as we see in the picture, butterfly rash appear on the cheek, both side of malar area, crossing the bridge of the nose, appear as papular eruption in the face, called butterfly rash. The non-specific skin lesion but suggestive skin manifestations of lupus are common and include alopecia, photosensitivity, Raynaud's phenomena, libido reticularis, urticaria, erythema telangiectasia, and cutaneous vasculitis. Renal, the other manifestation. So we speak about the clinical manifestation of SLE. أخذنا بالبداية skin manifestation. Now we have renal manifestation. The primary cause of morbidity and mortality in this population range anywhere from asymptomatic proteinuria to rapidly progressive glomerulonephritis with renal failure. The other manifestation is musculoskeletal, non-erosive, symmetric arthritis, most commonly affecting the hands, wrists, and knee, is typical of SLE. Central nervous system CNS manifestations include psychosis, stroke, seizures, and transverse myelitis, and are associated with poor overall prognosis. Cardiovascular involvement in SLE is classically manifested by vasculitis and pericarditis. Other manifestations include fatigue, depression, fibromyalgia-like symptoms commonly present and can be debilitating. Now we speak about the oral manifestation, the most important one. The predominant types of oral lesions are discoid lesions, erythematous, and ulcerations. So يعني البيشنت راح نلقى عنده كأورال ليجن SLE راح نلقى 3 احتمالات ممكن تصير عنده: الديسكويد ليجن، الاريثيماتس ليجن، أو نلقى الالسريشن. واحد من هاي الاحتمالات 3. The ulceration occur with increased frequency on the palate and in the oropharynx and are characteristically painless. يكون الألسر painless، وهذا يفيدنا حتى نفرقه عن other type of ulcer اللي تكون مصاحبة أو associated with pain. هنا الليجن واضحة بالبلد appear as ulceration, ulcerated lesion of SLE. Isolated erythematous areas are also common, especially on the palate. Discoid oral lesions are similar to those occurring on the skin and appear as whitish striae frequently radiating from the central erythematous area, giving a so-called brush border appearance. Laboratory findings. راح نشوف المريض ممكن شنو نشوف عنده إذا سوينا له laboratory investigation. راح نلقى عنده anemia of chronic type, leukopenia اللي هي تشمل neutropenia, lymphopenia or both. Thrombocytopenia are among the most common manifestation of SLE. Elevation of erythrocyte sedimentation rate with normal C-reactive protein level is characteristic of SLE. فهذه هي laboratory findings اللي ممكن تلقاها عند البيشنت اللي عنده SLE. Diagnosis of SLE is based on the compatible symptoms and signs in the presence of suggestive laboratory abnormalities. We have to do the diagnosis or to confirm the diagnosis of the patient. We have clinical criteria and laboratory investigation to confirm the diagnosis. Diagnostic criteria include acute cutaneous lupus, example, malar rash or photosensitivity and other. 2. Chronic cutaneous lupus, example, classic discoid lupus and other. 3. Oral ulcers or nasal ulcers. 4. Non-scarring alopecia. 5. Synovitis involving 2 or more joints, characterized by swelling or effusion or tenderness in 2 or more joints, and at least 30 minutes of morning stiffness. 6. Serositis. 7. Renal. 8. Neurologic disease like seizures and psychosis. 9. Hemolytic anemia. 10. Leukopenia or lymphopenia. 11. Thrombocytopenia less than 1000 millimeter at least once. So we have thrombocytopenia. Immunologic criteria include anti-nuclear antibody level above laboratory reference range. Number 2, anti-double-stranded antibody level above laboratory reference range. 3. Anti-Smith, presence of antibody to Smith nuclear antigen. 4. Antiphospholipid antibody positivity. 5. Low complement. A patient is having SLE is 4 of the clinical and immunologic criteria are satisfied. Treatment: corticosteroids remain the cornerstone of therapy in SLE and are especially useful for controlling disease flares. Dental management, we have important point. We should do it during dental management of patient with SLE. These include risk of infection, daily treatment with higher dose of prednisolone or other glucocorticoids, treatment with high doses of cyclophosphamide, and high disease activity are risk factors for infection in SLE patients. Complete blood count should be obtained before dental treatment of SLE patients, as leukopenia, neutropenia, and/or thrombocytopenia can occur. If possible, elective oral surgical procedure with the potential for bacteremia should be delayed until the absolute neutrophil count is checked. If an oral procedure cannot be postponed, prophylactic antibiotic can be considered. Risk of bleeding. Platelet transfusion have been recommended in surgical patients with a platelet count below 50% per cubic millimeter. Adrenal suppression or secondary adrenal insufficiency. A patient who received a glucocorticoid in doses equivalent to at least 20 milligrams a day of prednisolone for more than 5 days is at risk for hypothalamus pituitary adrenal suppression. Oral complications. Topical steroids with antifungal agents are recommended for discoid and ulcerative lesions. It is estimated that up to 20 of SLE patients will have Sjogren's syndrome. Sjogren's syndrome increases the risk of caries and other oral complications. So we complete the SLE. ننتقل إلى المرض the other disease اللي هو we called it scleroderma. Scleroderma refers to a group of clinical disorders characterized by thickening and fibrosis of the skin. The generalized form, systemic sclerosis, is a multi-system connective tissue disease in which the fibrosis extend to the internal organs, including the heart, lungs, kidney, and gastrointestinal tract. Women being affected 3 to 4 times as frequently as men. There are 2 main forms, systemic sclerosis and localized scleroderma. Systemic sclerosis is further divided into limited cutaneous scleroderma and diffuse cutaneous scleroderma. Patients with limited scleroderma often have a long history of Raynaud's phenomena before the appearance of other symptoms. Skin thickening limited to hands and problems with digital ulcer and esophageal dysmotility. Diffuse scleroderma. The patient have arthritis, carpal tunnel syndrome, marked swelling of the hands and legs. They also characteristically develop widespread skin thickening, progressing from fingers to the trunk. Internal organ involvement include gastrointestinal and pulmonary fibrosis, and potentially life-threatening cardiac and renal failure. Localized scleroderma refers to scleroderma primarily involving the skin with minimal systemic features. There are 2 major types of localized scleroderma: linear scleroderma and morphea. Linear scleroderma refers to or characterized by a band of sclerotic induration and hyperpigmentation occurring on the limb or side of the face. Morphea is characterized by small violaceous skin patches or large skin patches that indurate and lose hair and sweat gland function. As we see in this picture, female have morphea. Appear in the face. Etiology and pathogenesis. The etiology of systemic sclerosis is unclear, but the pathogenesis is characterized by vascular damage and an accumulation of collagen and other extracellular matrix components at involved sites. Clinical manifestations. Patients with systemic scleroderma or systemic sclerosis as opposed to limited scleroderma typically have rapid skin thickening and visceral organ involvement. Raynaud's phenomena refers to severe form of the digital cyanosis, numbness and blanching. Cutaneous manifestations include skin thickening of systemic sclerosis, patients being in the fingers and hands in almost all cases. The neck and face are usually the next site to be involved. Hyperpigmentation, telangiectasia also found. As we appear in the picture, as the patient can be seen, this patient have scleroderma. The 2 pictures related to the same patients. Telangiectasia appear as a small pigmented spot in the face. In the other hand, other picture, in the other picture, the hand of the patient appear, finger appear shiny, and the hardening of skin also seen. Musculoskeletal manifestations include generalized arthralgia, morning stiffness, muscle weakness. Gastrointestinal manifestation include esophageal motor dysfunction and gastroesophageal reflux disease, and the intestinal fibrosis result in malabsorption. Cardiac manifestations include ischemic, fibrotic, and inflammatory lesions in the pericardium, myocardium, and cardiac conduction system. Pulmonary manifestation include progressive interstitial lung disease, which can lead to pulmonary arterial hypertension. Renal manifestations include scleroderma, renal crisis. Oral manifestations: the lip become rigid and the oral aperture narrow considerably. Skin folds are lost around the mouth, giving a mask-like appearance to the face. The tongue can also become hard and rigid, making speaking and swallowing difficult. Involvement of the esophagus may cause dysphagia. Oral telangiectasia is equally prevalent in both limited and diffuse forms of systemic sclerosis and is most commonly observed on the hard palate and the lips. When fibrosis involves the muscle of mastication, mandibular resorption can occur. Mandibular movement may be restricted by muscular fibrosis, and linear localized scleroderma may cause hemiatrophy of face. Dental radiographic findings have been reported. Classic findings such as uniform thickening of the periodontal membrane, especially around the posterior teeth, are found in 10 to 37% of patients. As we see in this picture, X-ray of picture to patient with scleroderma, we can see the widening in periodontal membrane due to fibrosis. Other characteristic radiographic findings include calcinosis of the soft tissues around the jaws. The areas of calcinosis will be detected by dental radiography and may be misinterpreted as radiographic intrabony lesions, although clinical examination will demonstrate that the calcification are present in the soft tissue. Medication may reduce salivary fluoride, or patients with scleroderma may have secondary Sjogren syndrome. Xerostomia results in increased susceptibility to dental caries and candida infection. Manual dexterity is limited in scleroderma patients, which decrease their ability to maintain good oral hygiene. Oral hygiene can be complicated further if opening is limited. بهذا نكون أعزائي الطلبة أكملنا محاضرتنا بعنوان الأوتوإميون ديزيز، وإن شاء الله لنا لقاء قادم لإكمال باقي المحاضرات من مادة طب الفم. نلتقيكم على خير، والسلام عليكم ورحمة الله وبركاته.